Okay. Good evening, everyone. My name is Hadra Hassan. I'm a certified financial planner and senior advisor at TMFD Financial. I'd like to start off by thanking you for joining the webinar this evening, titled Embracing Implant Prosthodontic Solutions for Patient-Centered Care, Same-Day Implant Retained Restorations. And in a moment, I'll introduce our guest speaker, Dr. John Zarb. First, I'd like to take a moment to introduce TMFD and the valuable services we provide to our clients. Our goal is to make the financial lives of our clients easier by simplifying and putting everything under one roof. In our experience, we found that providing a one-stop shop for financial solutions provides clients with the comfort of knowing that all of their finances are synchronized. The result is simplicity, peace of mind, and confidence in your financial decisions. For those of you new to TMFD, I want to mention a couple of offers that we have. First, for owners and then for associates. So for owners, we have a dental practice assessment and financial review. The process highlights the financial health of your practice and identifies areas of excellence and areas that require improvement, as well as an estimated value of the practice. This is a service we offer to all existing clients. So if you're interested, please contact us. Second, for associates looking to purchase a practice, we help you guide you through the process. This includes a review of the practice cash flow and the loan repayment projections, as well as identifying areas of weakness and concerns with the practice, and then growth. And we can also refer you to bankers and so on as needed. More details about both of these offers will be sent out in an email after the presentation. And at this point, I'll hand things over to my colleague, Chris Malloy, and he is going to be managing the technology, so he has some housekeeping items.
That's great. Thank you, Hadra. And good evening, everyone, and welcome to the TMFD Dental Academy. Thank you so much for joining us this evening. As Hadra mentioned, my name is Chris Malloy, and I'm also a senior financial advisor from the TMFD financial team, and I'll be running things in the background this evening. Before I start, I just wanted to take a moment to run through some of the housekeeping items. So this webinar is scheduled to go to about 8 o'clock. It's being recorded and will be available on our website in a few days. If you have any questions for Dr. Zarb during the presentation, please ask them in the Q&A section at the bottom of your screen, and they'll be answered at the end of the presentation. If you have any questions for me behind the scenes or something you'd like to comment on, feel free to send a chat to the chat box. CE credits will be sent out within 2 weeks after the presentation, so no later than November 26th. Lastly, we encourage you to register for our TMFD Dental Academy mailing list so you can stay up to date with all our future webinars. So that's it for now on the housekeeping items, so I'll throw things back to you, Hadra.
So I'm very pleased to be able to introduce our speaker this evening, Dr. John Zarb. Dr. Zarb earned his DDS from the University of Detroit Mercy in 1995, followed by a general practice residency at the VA hospital in Ann Arbor, Michigan, and a master's in prosthodontics from the University of Toronto in 2002. He's a staff prosthodontist at Mt Sinai Hospital in Toronto, a clinical assistant professor at the University of Rochester, and co-director of Genesis Continuing Dental Education. Dr. Zarb joined Barry Dental Specialists in 2003 and is involved in implant dentistry education. Please welcome Dr. Zarb.
Thank you so much. Good evening, everybody, and thank you for choosing to spend your Tuesday evening with us. For this next hour, I hope to shed some light on my personal experiences and those of our team at Genesis in the realm of same-day implant restorations. I'd like to go ahead and share my screen. Okay. So first of all, I'd like to thank Chris and Hadra for their kind invitation to have me join you this evening. It's truly my pleasure to be here with you. I see, looking at the list of names, some colleagues who I know from across the province. Thank you for being here this evening. We are competing with the Leafs game, playing the Sens tonight. I hope to get you to the second will be done at the end of the first period, so hang in there with me. Like all of you, I stand on the shoulders of many impressive people who have had a profound impact on the information that I'm sharing with you today. And I'd like to thank and acknowledge them. Our team at Genesis is comprised of general dentists, dental specialists, dental assistants, lab technicians, dental administrators, who collectively have contributed to the body of information that I'm going to be sharing with you this evening. So my task this evening, the question that I've been asked to answer is looking at embracing implant prosthodontic solutions for patient-centered care. And, how do I do this? And I come to you this evening having been involved in implant prosthodontic care for the past 20 years now, I would say, but 30 years as a dentist. And what I'd like to share with you is the vantage point of looking at the reason why more of us are not involved in this care. So identifying the barriers to implant prosthodontic care. Looking back, speaking to many colleagues over these many years and having had an opportunity to have really embraced these protocols, like I said, for the past 20 years or so, I'm still at a bit of a loss as to why there aren't more patients who are the beneficiaries of this treatment. The penetration rate of dental implants in North America continues to be lower than other parts of the world, like in Spain, in Israel, in Brazil. And that's, I believe it's because maybe some of the ways that we deliver implant prosthodontic care is not as patient-friendly as it could be. And my task this evening is to highlight these barriers for you and try to make sense of them, because I think sometimes we can ask the question, why are we not doing something? And the list of these barriers will help hopefully shed some light on this dilemma. So I've categorized these into two main groups. There are patient-mediated barriers, and of course, there are dentist-mediated barriers. The bulk of my presentation this evening will focus on the dentist-mediated barriers, but I just wanted to kick off by underscoring what the known patient-mediated barriers are. In other words, if we had an opportunity to gather in a room and I asked the question, why do you think patients are not inclined to proceed with implant care? Time and time again, irrespective of geographic location, socioeconomic status, these barriers are what come up. And this is the work I'm borrowing from Michelle Reichman, who runs our practice management programming at Genesis. And time again, in her experience in surveying dentists across the globe, literally, these 5 main barriers come up: cost, value, trust, time, and fear. And Michelle has done a wonderful job at teasing out what these barriers are and then strategies to overcome them. The limitations of time tonight preclude me from being able to tackle this task, and I'd ask you, if you're interested, to come and attend one of her programs. I'm going to focus on the dentist-mediated barriers. I'm going to be speaking to you based on this experience that I have, but also shared experience from my colleagues at Genesis. And although this is not an exhaustive list, it's a list I think that hits most of the highlights, or as I've reflected on the reasons why patients, there aren't enough, or there are more patients who are saying yes to implant care. I think it stems from these 5 main barriers. Again, understanding it's not an exhaustive list, but I think they're the most salient ones. So the first one is that as clinicians, as dentists, as small business owners, we have this irreconcilable tension between selling and caring that plays a major role, I think, in how we present care and how we actually deliver care. And I was greatly influenced by this document, this paper shared to me by Carlos Quiñones, who's now at Western University, where they looked at the differences between the world of commerce and the world of care. And as dentists, we have this enormous privilege. There are 11,000 of us in the province of Ontario, a population of, I believe, 14 to 15 million, who have this enormous privilege to provide dental care, who can call ourselves doctors. And we were given this, we have this contract with society that allows us to do what only 11,000 of us can do, and that's to take care of patients. And our only responsibility in the grand scheme of things is to provide care, is to care for fellow human beings who need our services. So care is the goal. Care is primary in what we do. Money, of course, is a derivative of care. which if you look at the column on the left, is in reverse, because in the world of commerce, the only objective obviously is to make money, and CEO of a corporation would be fired if they did not pursue every avenue to grow their business and to provide dividends for their stockholders. In the world of care, in the world of dentistry, our goal is to take care of patients. It's important for us to be cooperative amongst ourselves. It's important that we base decisions on science, and that patients really can't compete with us. They do not, irrespective of Dr. Google, they do not have the capacity to fully understand the evidence as we do, because they're not trained in this field. So this tension that we have, I think, sometimes gets in the way of our decision making, the services that we offer, and poses some challenges. As we know, the purpose of the doctor-patient relationship is care of the patient. That's where it starts and that's where it ends. That's why we exist as doctors, and why we have this enormous privileged position in society. So I would say that this tension that exists amongst us, the need to care, the commitment to caring, the responsibility to caring, but also the need to provide a livelihood for ourselves, our families, and for our team, sometimes puts us in positions where decisions are made that are conflicted as a result of that. The second known barrier to me is having a profound understanding of what patient-centered care is. And I'm sure all of you on this webinar this evening, as well as any dentist that one may survey, would say that they practice patient-centered care. It's just part and parcel with who we are and what we're trained to do. What I'd like to share with you tonight, again, just my observations over time, is that patient-centered care actually is key to allowing us to provide solutions that are actually what's best for patients through the lens that they see. So a simple example would be if we thought of care of the patient journey rather than the dentist journey in the delivery of care, it may change how we conceive of doing things. And this was my realization, like I said, about 20 years ago, in the value, the merits of providing same-day implant solutions. Whereas prior to that, patients, at least in my opinion, had to suffer through some pretty inadequate and poor substitutes for teeth as they were healing. That journey was so poor for so many patients, that fear of that transition was so critical to them that very often they stayed away from reaching out to dentists for the care that they absolutely needed. And so if we just look at there's an enormous body of evidence on patient centricity in medicine, and this is just one example from the New England Journal of Medicine. We have to think of patients as partners in care. There are some very distinct benefits that come from this focus of thinking of care not through the lens of being a dentist, but thinking of care through the lens of being a patient. In other words, if we have the capacity to take a tooth out, or multiple teeth, or an entire dentition in one or both arches, place implants at the same time, and immediately provisionalize, that's a much easier journey for a patient to go through, provided, of course, that the outcome's not compromised, than having to go through the multitude of steps involved with having to graft, for example, sites, and the delay of care, the delay of getting to the finish line, the multiple surgical interventions that come with their own implicit risks, morbidity, additional cost, etc. I'm not saying that immediacy is a silver bullet. Of course, nothing is, but it is surprising and remarkable to me after all these years how often it can actually be provided for patients, allowing them to say yes to care that otherwise they would just shy away from. So if we just look at the body of evidence in terms of outcomes of patient centricity, studies have shown in medicine, but I would probably argue that it'd be the same in dentistry, that there's improved satisfaction scores among patients and their families, enhanced reputation of providers among healthcare consumers, because patients will seek out solutions that make sense to them, that overcome the barriers of time, of fear, right? We know that fear continues to be the #1 deterrent for patients to seek care. They'll rather suffer in silence than actually look out for our services. It provides better morale and productivity amongst clinicians and their team. It also is a source of improved resource allocation. It's an incredibly efficient way of providing care. And ultimately, which I think is also important as we talk about this balance, this tension between commerce and care, it results in reduced expenses and increased financial margins throughout the continuum of care. Each procedure is typically a bit more involved, but because there's such an appeal for it, as dentists, we actually get to do more of it, which I think is quite remarkable. The third dentist-mediated barrier that I'd like to flesh out with you this evening, and this is one I'm going to spend the longest on, is to really try to understand what our prosthodontic solutions are. Because if you're not immersed, I think, in the world of implant prosthodontic care, then it's something that we just dabble in or get involved in very peripherally. I would argue in 2024 that implant prosthodontic care should be integral to every dentist practice. Some dentists may choose to be single providers of care where they're full control of the entire process. And others may want to just be involved in the restorative end, which is just no different than being involved in the restoration of teeth. Just a matter of actually embracing it and being set up for it. But there are a lot of challenges that exist in the world of implant care, which makes it confusing. The parts and pieces themselves, with the understanding that there are, at last count, I think about 500 different implant producers in the world with different lines of implants and associated componentry, makes it very difficult to stay on top of this, to actually maintain the appropriate inventory, even if it's just at the level of restoring alone. Different drivers, understanding the nuances of the different torque that one has to apply to prosthetic screws, button screws, a whole host of things. So if it's not familiar, obviously that in of itself becomes a barrier. One becomes reluctant in embracing this kind of treatment. The other issue too is that industry, for better or for worse, has continued to innovate. I think for better in that today we're living at a time where we have incredible products to rely on, which is quite different than when I started my journey in the 90s, where we just had machined implants with an external hex, and that was the extent of it. Today, innovation has been enormous in the pursuit of being able to take a tooth out and place an implant and achieve a primary stability that's so key to being able to immediately provisionalize. But if you don't, again, not involved in this often enough, it becomes quite difficult to stay on top of the merits of one system or the other, or the innovation from one brand to the other. And of course, there's a simple solution to this: is surround yourself with colleagues, with mentors who are very keenly engaged in this, and just be part of that circle of knowledge transfer. The language that's involved in implant care is also very confusing and for sure a barrier. Amongst ourselves, there's terminology that's not necessarily standardized, which I'll show an example of in just a moment. But also for our staff, right? It's difficult for our staff who have to maintain all the hardware to support our journey in implant prosthodontic care. Makes it a bit confusing and somewhat of a deterrent, I would say. So let's focus on a few examples. I'm going to really highlight the two that have truly transformed my career, and that's the provision of implant solutions for the single tooth as well as for the full arch. So this was a patient I treated in the 90s. I just want to do this for historical reasons to focus on that patient journey. This patient presented, as one typically does on a Friday, with a fractured central incisor, a young adult who had had previously an accident as a child, regrettably had to have the 2-1 endodontically treated, post and core, and a crown. And sure enough, more trauma later on as an adult resulted in a vertical fracture and a non-restorable root. At that time, so just place yourself here in the 90s, for those of you old enough to remember those days, in the 90s, we only had a machined surface implant. We didn't have immediate protocols. We didn't really have much of anything that we could offer this patient other than an appreciation that cutting down 2 healthy teeth in the form of the 1-1 and the 2-2 was a bad idea. We definitely knew that the biologic cost involved in sacrificing those teeth did not make sense. So we're desperate to try to preserve what's there. We also knew, as all of us tonight know, that when you take a tooth out, we're starting a process that is bigger than us in terms of the soft and hard tissue changes that occur with time. The thinking at the time for this patient was to extract that tooth, provide her with a removable partial denture with a meticulously finished ovate pontic prosthetic tooth for the 2-1. And really, one wasn't religious, you became religious in hoping that you were going to maintain that tissue and you were going to maintain that papilla in the context of time, because everything was done in 2 stages. So the tooth had to be extracted. There was no socket preservation, already mentioned a bit at the time. Then after a period of several months, the implant was placed, buried, and then uncovered at a later stage, resulting in this kind of outcome with a machined surface implant, an external hex, again, like I said, in 2 stages. So the reason I put this up there is that at the time, this was what we knew, this is what we were doing. And the patient journey was horrible. This is a young person in their early 20s, really struggling with a removable prosthesis that, without a doubt, I know this because I heard about it from her, struggled socially as a result of this. It really did nothing for her social life over several months. If I'm not mistaken, it was close to a year before we actually had this tooth placed. A nice result, evidence, of course, of a small black triangle here, which made sense. And this had a profound impact on me and many of us at the time that, yes, we had a solution, finally, implants. After the 1982 Toronto conference, we had good data, even in the single tooth realm, to prescribe them. But the delivery from the experience, on the patient front was still really quite primitive. So with that as a backdrop, we fast forward then to the advent of treated surface implants, and then all of these new concepts of immediate, delayed, early, different aspects of the delivery of how the timing of how we could take care of somebody like I just showed you. Again, one of the challenges to this day still lies in the lack of harmony amongst colleagues presenting from the podium or even in the literature itself on what these terms actually mean. One of the biggest challenges, too, from a clinician standpoint, particularly from our surgical colleagues, is that the risk in a 2-operator system where you have somebody placing the implant and a different person doing the restoration is a sense of responsibility of what if, right? What if this doesn't work? What if it doesn't take? Who's going to manage the needs of this patient? Because all of us know that that's just one aspect, but besides that, there are a whole host of factors that will have an impact on implant success. And so, when this was started in the early 2000s, people were really concerned about the risk, right? Doing a risk assessment, you're placing an implant in and you're going to put a tooth on it right away. And yes, you're going to manage the occlusion, but how safe is it in the context of? I understand that, and we all do, and we can understand the hesitation. But that really those were concerns for a certain time in our history, 20 years ago. There's no doubt in my mind that fast forward to the recent past, this is no longer of concern as long as one really appreciates how the area should be managed, how important it is not to disrupt the blood supply, where to place the implant accordingly. And I'm going to try and share this with you. So if we look at that conventional timeline, the tooth is extracted, the implant is placed several months later, and then a restoration. And the patient is literally limping along during this journey. Here's a case shared with me of a central incisor, non-restorable tooth. We all know that the only option is to remove it. You're staring down that dark black hole. If you do nothing, this will fill, 80% of the socket will fill with bone. You're going to lose some height, you're going to lose some width. So probably not a good idea. So one of the conventional ways to this day, and definitely appropriate in specific cases, is to do some guided bone regeneration, place an implant with a healing abutment, thinking of the patient and they're limping along and wearing something pretty atrocious. So there's no doubt that there has to be a better way. There had to be a better way. And of course, the advent of moving from machined surface implants to surface treated implants with the right topography, namely in the form of the Nobel Active implant from Nobel Biocare, I think really changed, at least equipping us as clinicians with options for our patients. It's really important, and this is my very obvious bias, that implant care needs to be seen through this lens. It is truly a prosthodontic solution that has an important surgical component. But like building anything in life, we can't really build a foundation without really knowing what's going to lie on top. So the focus has to be on the tooth, the multiple teeth, the full arch, as the driving force. The surgery has to be at the service of the restorative solution. And that's why it is my strong belief that all of us restorative dentists should be engaged in implant prosthodontic care. So for clarification, if there's any doubt, immediacy is, as defined by myself, by many, and particularly by our team at Genesis, is immediate implant placement, typically following extraction, and immediate provisionalization. So just to highlight this, this is in very simple terms, the tooth's extracted atraumatically. The goal here is always to do this without reflecting a flap, to ensure that we don't disrupt the periosteum, which is so key to reducing the morbidity, allowing a patient to have a very seamless experience, particularly for a single tooth. This is the sort of thing that our patients can have done over their lunch break. It's not a big deal. Placement of the implants, it's placed deep and palatal to allow for screw retention, to allow for appropriate emergence profile, and immediately provisionalizing, making sure that other than a bolus of food, the patient's not able to bump this restoration. And that has to be done sometimes at the expense of length. The provision may have to be a bit shorter, or has to be done at the expense of it being slightly proclined. This, in my opinion, just my opinion, is not immediacy. This is taking a tooth out and putting a healing abutment, has little to no value to patients. They can't even make sense of a healing abutment. What patients seek from us are teeth, and not so much even the teeth. They just seek the comfort, the confidence, the peace of mind that they can carry on their merry way. So when is it appropriate? When is extraction, immediate placement, and immediate provisionalization appropriate, and why? Well, why would we do this? And this has been, I can share with you after being engaged this for so long, that this list here kind of really summarizes the recurring reasons why we're continue to be so excited to provide this care. Number one, it reduces the number of surgeries and associated morbidity. Understanding that fear is one of the main patient-mediated barriers to implant care. If you can have a conversation, if your staff, your treatment coordinators can have a conversation that this will just be one surgical procedure, they have to have a needle just once, it's something that patients can really get their head around. So that's, I think, a key piece. And not to mention that by doing this in an atraumatic way without reflecting a flap most of the time, almost always, then it obviously decreases the associated morbidity. As a result of that, there's increased patient comfort during the healing phase because the tooth now almost acts like a Band-Aid. There's nothing for food to collect into, and it just means they transition so easily. One tooth comes out and a new one goes in. In my experience and our collective experience at Genesis, it also allows, very importantly, for the preservation of hard and soft tissue, the architecture surrounding this tooth, which is key to end up with an excellent outcome in time. Because we know that if we don't do this, then we're setting ourselves up for for several more interventions that come with increased morbidity, increased cost, and quite frankly, not particularly attractive to patients who are not so keen to begin with to have lots of surgery. And without a doubt, I think the most important reason, which is what patient centricity is about, is just it's more appealing for them. It appeals to their own experience, their journey as they navigate through the impending loss of one or multiple teeth. So very simply, because time doesn't allow for a deep dive into the evidence, but I assure you there's a significant body of evidence to support these protocols. In very simple terms, the product I described to you, I'm going to share with you with some case histories, is that if we can achieve an initial implant stability of preferably 35 or more Newton centimeters, and if we can control excessive off-angle bite forces, then we can predictably immediately provisionalize. And this has been sort of at its core the steps that we take in evaluating these patients before their treatment. We also know that industry has really been very supportive of providing us with the appropriate tools by the intent, very extensive research and development to develop surfaces at a macro and micro level that allow us to shorten the time frame when implants are most vulnerable. And this is the work that I'm sure a lot of you are familiar with. So that if we have the right tools, so choosing an appropriate implant, undersizing the osteotomy, we know that we can always make a hole bigger, we can make it smaller. And sometimes we have to engage an opposing cortex to get that primary stability. We're able to deliver this service more often than not. Because really and truly in our head, the person providing the care, we need to do what we can to limit micromotion during that critical time frame when, let's go back to this graph, when the implant's going from that stage of primary stability, the graph you see on the left, to secondary stability. And the surfaces, the topography, the macro architecture allows us to do this. So, three-part strategy. Once again, really simplifying this because understanding that there's a lot of layers below this, but conceptually, this was my goal tonight, was to share the rationale behind this approach. We need to have good initial stability. We need to be very mindful of the occlusion and to protect it, particularly from lateral tangential forces. We know implants right away can be subjected to enormous axial forces. They do well under compression. They don't do well, obviously, under lateral tangential forces. And so we have to protect these, particularly in the anterior maxilla, in protrusion and lateral excursions, that our professionals are protected. And we need to have good patient cooperation. It's motherhood and apple pie for all of us, but it's a key conversation to have with patients. And obviously, it's part of our determining whether a patient is a good candidate. Industry has helped us with new surfaces, new designs. Both the main leader was Nobel, who came out with this. Straumann is focusing on 2 premium brands tonight. We're a bit late to the dance, but have now come up with also the equivalent excellent implants that allow us to provide these solutions. And we can actually do this for posterior teeth too. Again, from that understanding of how well implants do under compression. But we have to be mindful of the design of the transitional restoration to have a low cusp height, a narrow occlusal table, and for them to be completely out of occlusion. So there's lots of scope. If we were trying to replace tooth number 1-4 in the image on the far left of your screen with a robust canine, I would have little hesitation to do that. But quite a different story, obviously, when we lose the guidance that one gets in the protection from a canine, as you see in the middle image. A different story. You may have to immediately provisionalize the 1-4 with a shorter crown, narrower occlusal table to make sure there's no scope for any lateral forces. And one needs to be very mindful of the stability of the adjacent teeth, where sometimes, obviously, immediacy would not be indicated. So let me just walk you through a simple case. Patient presents with a 2-1 with history of external root resorption. This is what they look like, an occlusal view, just to give you a sense of the thickness or lack of soft tissue. The tooth is removed atraumatically, really key in a patient with a smile like this. I'll show you a smile in just a few minutes. The associated biotype, really, we want to be as minimally disruptive as possible. So the time it takes to extract a tooth like this is actually quite significant, because we don't want to jeopardize having to pick up a scalpel and reflective flap. Once again, we're looking down this dark black hole, and we need to make some decisions here what we can do. And there are lots of options. My role tonight is to focus on the immediate option, which is to place an implant, engage that palatal wall where we have highly corticated bone, place it deep enough so we can create an appropriate emergence profile, and obviously screw retention of our restoration. That's the story for the single tooth. I'm going to switch gears now and focus on the full arch for a few minutes. And the full arch treatment today, the restorative material of choice is zirconia, and we've moved away, thankfully, from veneering zirconia. We're using microceramics to end up with really attractive results with having the benefits of the strength of zirconia, and also being able to using microceramics to get the appropriate aesthetic presentation. No material is without its own implicit weakness. They all do, because there's no material in implant prosthodontic care that was designed exclusively for implants. We've always borrowed from the restorative materials we have for teeth, and that poses some challenges. So if we're going to get involved and embark on taking care of patients who require full arch, we need to take a good look at certain things in advance of even considering this treatment. And this, once again, is not an exhaustive list, but I want to remind you, this is a prosthodontic solution, once again, with a surgical component. So we need to know where the teeth are. We need to have a sense of where the smile is. We need to be mindful of the transition zone to be sure that we can deliver a result without compromise. I'm just focusing on 3 things: smile line, transitional, and gingival emergence. And so if you have a patient with a favorable smile line like this, it covers a lot of things. If you retracted that lip, you can see a porcelain fracture. This is an old picture where at the time we were using PFM restorations that not sometimes, but always chipped, broke, cracked at some time in the patient's life. It was provided enormous limitations. So a smile like this is quite favorable. You have to think of the smile like the bed skirt that we have at home, or if you have any teenagers at home, where lots of stuff is hidden underneath it. But we really need to make sure that that bed skirt is long enough that it does indeed protect what one can see. A big no-no in full arch treatment or any implant treatment is the transition zone, and that's the junction where the patient's existing gingiva, they're pink, and the artificial, the prosthetic gingiva, are pink, come together. The two can never be seen together. So one has to be very mindful of the scope of the patient's smile to ensure that this never happens, because you can't fix it. Another key thing from a hygiene, from a maintenance standpoint, patient comfort, is to the way that the ridge is prepared to allow for a highly polished intaglio surface. So let's say a maxillary all-on-5 full arch treatment here will sit very nicely, compressing that tissue, making sure that there are no issues with speech, with blowing bubbles, with airflow, as well as the patient's ability to maintain the tissue. Quite easily achieved in the maxilla. We typically have a lot of nice attached tissue that we can work with from the outset. A bit more challenging in the mandible, where we're very limited with the amount of attached tissue. We have to be very delicate in how we divide that. But always a reminder with any implant-related restorations of how key it is to have attached tissue around, in this case, the SRAs from Straumann, and from a patient maintenance on a daily basis, but also in the context of time. So we can take a patient like this with a terminal non-restorable dentition, use some very simple diagnostic smile design that comes with most intraoral scanners today to start to get an idea of where the teeth belong, teaming up with a lab that has a really good appreciation and understanding of how to do this, so that the guidance they provide us in terms of the amount of ridge reduction is actually appropriate and not excessive. And going through these steps, then combining the intraoral scans, the cone beam CTs, we can do lots of planning, and you can then use that information to provide the surgery in a guided manner or in an analog manner. It really doesn't matter. What's key is this time spent in consultation with all the stakeholders involved, the person doing the surgery, the person restoring, and the lab, to make sure that we actually have a plan in place. The software today really allows for that. The lab can then design the position of the teeth, establish, if any vertical dimension of occlusion has to be changed, if the position of the teeth have to be changed, and come up with a prosthesis that we can then convert for on the day of surgery. Here you can see a hyperrupted molar in the second quadrant. Obviously, that's going to be addressed in the restoration itself. I'll just fast forward. We typically mill these prostheses and then bond the prosthetic teeth to the pink base, and we go to surgery with the prosthesis ready to go. We can do a pickup, impression, and convert from a denture to what you see here, an all-on-5 in the maxilla, and the classic all-on-4 in the mandible. Nice distribution of the implants, good anterior-posterior spread, with a transitional that's highly polished, glazed, and really going to be tissue-friendly, allowing the patient to take care of this and maintain it very nicely in time. And this is the result. The last two barriers are ones that I'm just going to gloss over only because of the interest of time. We all have, by choice, but also out of necessity, made a commitment to a lifetime of learning, and that comes through the requirements for licensure to have 90 hours of CE every 3 years. But then it's really up to us, apart from some of the core one things that we have to do in Ontario, but it's up to us to choose education, to pursue education that's of interest to us. The reality of practice, though, particularly if you're a mid to late career like myself, who lived very comfortably in the world of analog dentistry and has seeing things changing so dramatically in these last 5 to 10 years in the digital world, there is this commitment to having to stay to keep up with it. And that leads me to the comment on keeping up with technology. We know that the train left the station a long time ago. And if you're late career, we may sort of ride this out to be able to still do things the way we did before, anywhere from our diagnostics all the way to the delivery of care. But if you're a new dentist, a mid-career dentist, there's no choice but to jump on that train and hopefully get on it sooner than later. Because as an educator, what's really apparent to me is that it's not just about keeping pace anymore. It's about us taking a lead to changes in technology, to innovation and education. Thankfully, I think for the better, although it doesn't always appear that way, we're practicing at a time where, especially on the diagnostic end, which I'm going to share with you in just a moment, There's so much valuable information we have. So what are some of the solutions to overcoming the barriers I've identified for you this evening? How do we stand out in a crowd? If we're that person, how is it that patients are going to seek us out for the care that we provide? I firmly believe that immediacy, adopting same-day solutions is definitely worth considering. We live in a society where patients are used to dropping off their laundry in the morning and picking up in the afternoon. They're used to coming to your office and having a crown done in a day, not having to come back 2 weeks later. They're used to having glasses done within a day or within an hour. So there is a certain expectation of efficiency, recognizing the barrier of time as being an important one in the eyes of many patients. I would urge you, as you are, I'm sure, already to make sure that every patient has a good documented series of photographs, really capturing their smile, understanding that this is the same person who, when was asked to smile, the image on the left, presented this way, after conversation, becoming more comfortable, presented with a second image, and then after laughing, really revealed what a broad and generous smile she had. No matter what we're doing, it's so critical that our team members capture this for us as we embark on our planning. If we were planning, let's say, to do any treatment in the anterior maxilla, we have to be prepared that the patient has the capacity to smile as broadly as this, irrespective of the dental treatment. Also, taking advantage of intraoral scanners, which to me is a really powerful diagnostic tool to educate our patients, to capture where things stand today, allows patients to virtually sit on their tongue and look out and see how limited prosthetic space we have to restore their worn down dentition. It also allows us in time to monitor and be aware of changes to hard and soft tissue because the software can do that for us. So these are really powerful, simple, but very powerful tools we have. The last thing I want to leave you with as I'm getting close to wrapping up here is really and truly, I think what we've learned, what I've learned most from is having the benefit of mentors who I continue to lean on, colleagues and dentists that I work with in my own practice at Genesis, but also just colleagues I've met over the years. But I think the education that has really stuck with me is what I've learned from patients themselves. And I just want to share one case history. Excuse me. And that's my patient, Joan, who continues to be a frame of reference for me and my team. Joan is an 82-year-old patient who presented with a partially edentulous maxilla and mandible and a failing dentition, essentially. At 82, she'd been looking around for a solution that allowed her to be able to continue to live her life with the same degree of energy, socialization, desire to travel, to entertain, be entertained. And the solution she was being presented to her, I think, regrettably, from our community were removable solutions because she had been wearing removable prosthesis for so long. She had some concerns. Her family members had concerns about anything else. When we met, we were able to assess her, obviously, as one does. And she was committed and wanted to have fixed teeth. She wanted to live the remaining years in her life not having to think about taking her teeth out at night, editing what she eats, trying to, struggling with managing removable prosthesis that comes with its own strings attached. So Joan was a wonderful person who embraced immediacy, was seeking this solution, irrespective of her age. This was something that she went after, and sure enough, that's what she got. It's something as simple as the placement of 4 implants in each arch, retained with a titanium bar and denture acrylic teeth. This is a viable solution for her that gave her this new lease on life, allowing her to continue to live well into her early 90s as she's doing now. So, I think sometimes we approach patient care with some expectations or presumptions, which regrettably I think get in the way. So in conclusion, what I can like to share with you this evening is that from my experience and looking through the history of implant care in our community here in Ontario, what I can say to you, and I'm sure you'd agree, that it's really not about surgery or grafting. And if you look at cases like this, it doesn't make sense that we even thought that this was appropriate or acceptable back in the 90s when this was happening with abandon. I would say that in my experience and just in my opinion, I don't even think it's about teeth. I think what patients are really seeking is what happened to this lady, the lady with the 2-1 who presented for a post-op 2 weeks later with her transitional in place. who's able to, again, came in to have her care done over the lunch hour, continued with her life as if nothing ever happened, allowing her to smile. She has a lovely smile here, providing her with a solution that was minimally invasive, really simple in terms of delivery. Not so much that it was easy to do, but simple in delivery, at least from the way she proceeded and went through it. The same goes for full arch treatment. Here's a patient, and this is her 2-week post-op. This is the same individual. It looks like her younger sister. You can see what she started with and how the impact of their smile really affects how they feel about themselves, what they wake up to, what they show to the world. And then in the matter of a day, because the treatment's done in a day, and then 2 weeks later, it's a new, truly transformative care. Always reminded of how wonderful this solution is. So in summary, then I like to encourage you to consider immediacy as a viable solution. In my opinion, it should revolve around patient care. It really is what drives the desire to pursue this care. It is more challenging. One needs to have some infrastructure to provide it. It's tempting to bail when a tooth is removed and an implant is placed, to just put a healing abutment on. But just a reminder that patients are not interested in that. What they want is teeth and the quality of life that comes with it. Without a doubt, it's a proven strategy for growth. It's not just a procedure or technique. It does require the team approach. It's critical that our teams are trained, appreciate what all of this means so that they become ambassadors for the care you're providing. And by keeping implant solutions simple and predictable, there's a greater appetite for it for patients to want to seek it and say yes to it. I'd just like to leave you with a quote that resonates with me, and just as a reminder for us as we gather tonight on a Tuesday evening, and want to thank once again Chris and Hadra for hosting this evening. That it's really important. I think all of us, we have this enormous privilege as dentists to do what we do. We're really very lucky to do what we do. We've earned it. We work hard at it, but it still is a privilege, and we can't lose sight of it. And I think all of us contribute in making our society a better place for everyone. With that, I'd like to thank you for your kind attention, and I'm happy to entertain a few questions in the next couple of minutes.
Thank you, Dr. Zarb. That was a great presentation. And I am looking to see if there is questions. Give me a moment. And there's none at the moment. We also, by the way, missed our polling questions, but oh well.
Hajra, I just want to point out there's some questions in the chat box.
Okay.
And I apologize to Chris and Hajra that I did not request the polling questions, which I said I would. We have some polling questions. Maybe we should do those now before.
It's okay. Let's do the questions.
Sure.
I have two questions. Firstly, you mentioned that your clinical impression was that immediate restoration helped to preserve the hard and soft tissue. Can you summarize the Can you summarize what the consensus is from reliable published literature says on this issue?
So this must be Mari Arlen asking this question, would be my guess. Mari, I don't have at my fingertips the latest evidence to support. I can only reference some of the work of Joseph Kahn and others who have followed these patients. I can share with you from our experience of having placed, I think, close to 11,000 single implants to date, and following them quite carefully and closely. We're actually in the process now of having our data being assessed by the statistician for publication. So I'll be very happy to share that with you once it's available for publication in a peer-reviewed journal. So I don't have at my fingertips maybe the clinical evidence that you're asking for, but I can tell you empirically, anecdotally, only because it's just been doing it for so long, that the method of placing the implant in an atraumatic way, not disrupting the periosteum, not really caring too much about the presence or absence of buccal bone, which is typically the case around teeth, really allows us with the placement of a highly polished provisional restoration to support that tissue in the long term. Having seen my same patients, having practiced in the same location for 21 years, that's been my anecdotal experience to share with you. Your second question is there a significant cost difference between immediate fixed temporization versus an interim removable prosthesis. I don't believe so, but quite frankly, it's really not a question that I'm concerned with, because in my opinion, it's just my opinion, to be able to achieve these results, immediate provisionalization is a must. It's not an option, so it's just built into the care for the patient. And one just has to be clever and creative in a way to make sure that there's value to the patient in understanding. If patients are given a choice and presented care on a la carte menu, they're always going to choose obviously not always, but they're often going to choose the least costly way of providing care. And as I said at the beginning of my presentation, they cannot make that decision on their own. They can't appreciate the evidence, they can't appreciate the value. And so we are not concerned with making a provisional is not a source of revenue. It's just because it's the right thing to do. And it's an important thing to do to preserve the hard and soft tissue.
We have another question. Do you ever have cases when you plan to do immediate implant and extraction goes more complicated than expected?
So, Yulia, thanks for your question. Yes, of course that can happen. So I don't want to mislead anyone thinking this is a silver bullet that happens all the time. But it happens, we're able to deliver this most of the time. And the reason we are able to do this is you can approach this in an analog way, or you can approach it in a guided way, and having the benefit of CBCT and an intraoral scan gives us a lot of diagnostic information also to choose our cases appropriately. Let's look at our endodontist colleagues whose batting average has improved dramatically with the advent of CBCTs, because they're no longer endodontically treating teeth that are hopeless to begin with, because in the past they didn't have that information. Now they can see very clearly if a tooth should or should not be treated endodontically. It's the same with single implants. The approach, I think, is really key. This is the lesson, the take-home lesson that I have really sticks with me is the conservative nature of the surgery, of removing that tooth, a fractured tooth, very diligently at the expense of the tooth, not the bone or the soft tissue. Preservation of blood supply is key to a predictable result. So what surprises me to this day is how often we're able to do this without having to abort and move to a different approach.
We have another question. What are your considerations with an infected upper first molar for immediate placement?
So Imran Khan, thanks for your question. Yes, so obviously if it's infected, then one has to make sure that the source of the infection is removed. It's typically the tooth, and all that granulation tissue is removed, and then take a hard and long look at is what you're left with, is it adequate to be able to get stability of an implant. We don't take out healthy teeth. We only take out teeth that have a problem. So they're mostly infected teeth. I think it's would be disingenuous to suggest that you can do this in the absence of infection. If there's infection almost all the time, so it's critical to spend the time to really debride the air, remove all the granulation tissue, and then do a careful assessment. And if it's not appropriate, it's not appropriate. You have to have a plan B, and this is where it's important to be aware of other approaches. Once again, what's remarkable is how often one can actually go ahead and place an implant. And we follow these patients now, not for 1, 2, 5, but 7, 8, 10 years, and they've done extremely well.
We have one from an anonymous attendee. Is there an absolute contraindication for immediate implant and transitional restoration, like a Bruxer?
Absolutely. So if you cannot control the forces on your provisional, then it would be a bad idea to go down this path. One risks that the implant, when it's most vulnerable, particularly in those first 2 weeks, basically coming loose and falling out. And so if you have a patient who's a Bruxer, I would still proceed with extraction, immediate placement, and then I would make a customized healing abutment. So I'm preserving the tissue and provide them with a substitute like an Essex retainer or a removable partial denture.
Norman Finkelstein, does immediate restoration have the same success rate as delayed restoration?
Thanks, Norm, for your question. To the best of my knowledge, the evidence that exists today is yes, but the numbers unfortunately are not very big. They're not very large in comparing the two groups that you've just identified. So I don't think we're comparing apples to apples. We took it upon ourselves to adopt this approach. We've now been doing it for the last 20 years. And that's one of the privileges of working in the same office, the same communities to follow these patients year after year. And I assure you, if there was any risk, we would have changed our course of action a long time ago.
I have another question from Dr. Murray Arland. Do you
Of course
think
you
do you think the socket shield technique is a viable option to help preserve the facial hard and soft tissue?
So Murray, thank you for your question. I know little to nothing about that technique other than I'm aware of what it is. It doesn't make a lot of sense to me, having looked at dry skulls and really appreciating that most human beings have some form of fenestration or dehiscence in the anterior maxilla just by the very nature of the anterior maxilla, particularly as we age. And yet they're not walking around with big gingival defects in terms of the soft tissue support. So the approach that you're describing definitely does not work. I would say it would be tricky for it to work in the hands of every dentist wanting to be involved in implant care. And so for me, that's a limitation. I haven't sought a need for that. We know that if we can take a tooth out, tease it out without disrupting blood supply, placing an implant deep in palatal so we get stability, relying on the prosthesis, the crown, to support the tissue, as long as we don't touch the mesial and distal bone, which is really key to preserving the gingival zenith, in my opinion, then I don't see a need for that approach.
There was one question that we kind of went over, how to preserve bone in posterior area by extracting. It often goes unpredictable in molar areas.
Yeah, I apologize. I'm really not an expert on bone grafting procedures. It's not within something that I have a lot of expertise in. So regrettably, I can't answer that question.
Okay, so we'll pass on the last question. And in the interest of time, because it relates to bone grafting again.
Sure.
So
actually, I can answer Elliot's question.
okay.
Do you tend to need to perform bone grafting at the time of extraction, immediate implant placement? Thanks for your question, Elliot. Yes, so there is some element of bone grafting, but it's really not so much in the spirit of trying to rebuild what's missing. It's really just designed to fill the gap. As you know, when we extract a tooth, we place an implant, we're going to place it deeper. So there's going to be a gap between the implant and the socket. And there are lots of opinions about how big that gap should be or how small the gap should be and the need for grafting. We typically just use an allograft just to fill that space so that we don't get collapse of the tissue. We're really relying on the immediate provisional to actually provide the support, and we're relying on not disrupting the mesial and distal bone, which is actually what's going to hold our gingival zenith. So some grafting is required, but it's actually it's just really a matter of just placing a filler.
Thank you, Dr. Zarb. In the interest of time, we're right at 8 o'clock, so perfect timing. I'd like to thank you for sharing your knowledge with the dental community. And I'd like to thank everyone for joining us this evening. In the coming days, a video recording will be posted on our website, www.tmfd.ca. You'll also receive a brief survey asking how you enjoyed today's presentation. So if you can share your feedback, that would be great. And please share with your colleagues, TMFD Academy. We'd love for people to join us again so that we can have collective knowledge. And a reminder, PACE credits will be issued within the next 2 weeks. And please stay tuned for information on our next webinar. And again, thanks so much, Dr. Zarb, for an excellent presentation.
My pleasure. Thank you to you and Chris, and thank you everybody for being here this evening. Those who are interested, the Leafs are of course losing.
Okay, good night, everybody.
Bye-bye.